foreign associate member of the National Academy of Medicine, formerly known as the Institute of Medicine of the National Academy of Sciences of the United States of America. He is the first Bernard Lohm Visiting Professor of Global Cardiovascular Health at Harvard School of Public Health. He is presently an adjunct professor at Harvard, Emory, and Sydney universities. So see how many people you can recall with that. He is only the third Indian to be made a fellow of the London School of Hygiene and Tropical Medicine in its 118-year-old history. He is the first Indian to serve as the president of the World Heart Federation. He was awarded the WHO Director General's Award and the Luther Terry Medal of the American Cancer Society for leadership in global tobacco control. He is an honorary recipient of doctorates from many international, very prestigious universities, and he has been conferred one of the highest civilian awards in India, the Padma Bhushan, by the President of India. Once again, one could go on and on. But I think we are not here to listen to his accomplishments, but we are here to listen to him. And with your permission, let me just say that Professor K. Srinath Reddy, as Professor Norton has pointed out, has been the oldest friend of the George Institute in India, helped it set up shop here, as not to use a local language, but has been a constant supporter. Now, even this morning, as he was preparing to come, he asked me whether we wanted him to give a technical data-driven presentation. And I said, we are here this afternoon to really find out what exactly are the major health challenges, how do we solve them. And we won't necessarily do it just by looking at the data, but we will do it by listening to a man who has the years of experience in analyzing that data, thinking about it. So we are not necessarily here to just look at the data, but we are here to listen from Professor Reddy about what he thinks that those data tell us, what he thinks are the big challenges in healthcare in India and also around the world, and how he perceives that we might be able to go at least some way in solving them and play a little bit of a role. And so I requested him to not necessarily give a PowerPoint presentation, but to share with us his thoughts around that. So with that, it's really my great pleasure and honor to welcome Professor K. Srinath Reddy and to present with him this citation. May I invite Professor Stephen McMahon, our Principal Director. The citation says that the George Institute for Global Health India is honored to present this scroll to Professor K. Srinath Reddy for delivering the George Institute Decennial Oration on Chronic Diseases in India, Challenging and Catalyzing Research and Converting Policy. This scroll is in recognition of Professor Reddy's impact on public health and the countless lives saved as a result. There is more text, but I won't repeat that because we are here to listen to Professor Reddy. Thank you, Professor Reddy, for accepting this. Now, may I invite Professor Reddy to kindly deliver his oration.
Your Excellency, High Commissioner Sidhu, Vice Chancellor, Professor Jacobs, Robin, Stephen, Vivek, ladies and gentlemen, and the young visionary leaders of tomorrow, the prize winners. It's a great honor to be here today at the 10th anniversary of George Institute India. It's been a sentimental journey, both from the time that I requested Stephen to come and sit with us in Hyderabad with the Bhairajya Foundation leaders and plan out how best we could tackle the issue of high blood pressure, diabetes, and cardiovascular disease, which they had identified as priority for their community-based interventions. A bit of history about that later on. Stephen and I had already been working together in the Initiative for Cardiovascular Health Research in the developing countries, which was set up in 1999 by the World Health Organization and the Global Forum for Health Research together in order to address the challenge of rising cardiovascular disease in low and middle income countries and trying to steer research towards prevention and control through effective health system interventions. While the Secretariat was initially set up in Geneva, and I was asked to be the first executive director of that, I decided that Geneva is not the best place to get anything productive done. And Hank Beckham thankfully is not here. And I decided that the Secretariat should be moved to Delhi. And after Professor Ken Shine, the president of the Institute of Medicine in the US, stepped down as the first president, we brought in Stephen McMahon to be the chair of the governing body of that particular initiative. And Stephen and I worked together to develop several programs, which the WHO actually adopted, both into the surveillance as well as the national capacity assessment, as well as in a number of other programs. But at that time, when the Bairaju Foundation asked for some technical support in organizing a surveillance program and then an intervention program in about 120 villages of the two Godavari districts of Andhra Pradesh, I thought the best person to provide that kind of technical advice would be Stephen McMahon, who already had done a tremendous amount of work in hypertension, cardiovascular diseases, and other chronic diseases. And therefore, Stephen and I met with them, and the first partnership was born. And then Stephen, Bruce, Neil, Anushka, all of them worked with the Bairaju Foundation and Rohina Joshi and others who did the work in the field. And that's been a very productive experience, demonstrating in the process that what was considered to be a rural India, which in popular imagination was relatively free from chronic diseases, especially cardiovascular disease, was indeed becoming the hotbed of cardiovascular disease, and that 40% of the cardiovascular deaths were actually occurring below the age of 64 years. So prematurity was a major issue. And the myth of rural India being immune, or even India being immune from cardiovascular disease, was being dismantled. But to go back a little in history, let me go back to 60 years ago, since we are talking about the 10th anniversary. Just about 60 years ago, at the WHO, an Indian delegate to the World Health Assembly demanded that a cardiovascular diseases unit should be set up by WHO. They never had a cardiovascular diseases unit. And therefore, it was a bit of a surprise that the Indian delegate was demanding when high-income countries were not actually asking for it despite their huge problem. And the interest in that particular request, voiced by Colonel Iyer at that time, was because of the major problem of rheumatic heart disease in India. And it was felt that low and middle income countries which had a high burden of rheumatic heart disease did not receive adequate support in that area. And also given the profusion of scientific literature that was pouring forth in India from juvenile mitral stenosis, Professor J.V. Roy and Professor Ramalingaswamy and others highlighting that area, and Professor Padmavati as well, it was considered useful to have that kind of support internationally as well. But as I mentioned, rheumatic heart disease was the major focus of cardiology at that time. And even as I did my residency in cardiology, fellowship in cardiology in the 70s, late 70s, still rheumatic heart disease was considered to be the dominant theme, whether it's the Indian Council of Medical Research expending its resources on research, or even in terms of clinical attention. But interestingly, again, about 60 years ago, 58 years ago to be precise, we had, in fact, a very different picture being noted internationally with respect to Indian cardiovascular disease. particularly coronary heart disease. So 58 years ago, Dhanaraj and others from Singapore published data in the American Heart Journal comparing Indian males and Chinese males, and that was Malaya at that time. And they showed that in the age group of 30 to 39 years, Indian males had a almost six-fold higher prevalence of coronary heart disease in autopsied cases. These are necropsied cases. And in the age group of 40 to 49, where again the prevalence of coronary heart disease was much higher, again there was a six-fold difference between the Indian males and the Chinese males. I did inquire from Vivek this morning, and I was very reluctant, in fact, to give a data-driven presentation. And I was trying to escape that responsibility of doing that kind of a presentation, but I wanted to double check with Vivek whether it's okay to do without a PowerPoint. And I promised him that I will not pulverize people with PowerPoint, that I'll not drown people with data, and I'll also not poison with platitudes. So I'll try and do some reflections, if I may, on how the whole approach to cardiovascular disease has evolved in this country, with a certain degree of personal reflection of my engagement, but not in any way diminishing the tremendous contributions of so many others, but essentially speaking from a personal vantage point, like the fly on the wall. So that was 58 years ago, and again 58 years ago, in Uganda, Schaefer and others said 43% of the deaths among South Asian men in Kampala were certified as due to coronary heart disease, while within the African population the disease was almost non-existent. We had many other cases coming up after that in terms of reports in various scientific journals from different parts of the world talking about the high rates of coronary heart disease in interethnic comparisons across the world, whether it was Balarajan and McGee in the UK, or Tumaleko in Mauritius, or Beckles in Trinidad, or Hughes again in, by now, what was Singapore. It was very clear that persons of Indian origin, whether first generation or third generation, whatever the time or climb of migration, were indeed exhibiting much higher rates of coronary heart disease and much higher rates of premature mortality due to coronary heart disease. And therefore, this mystery of the Indian coronary heart disease became a bit of an issue as to why there was not much of attention and research into that. Though there were some initial publications from Dr. Padmavati and others in the 1958 to 62 period on the epidemiology of coronary heart disease in India, it was still considered to be a problem of the affluent and the middle class in Delhi, and it was not perceived to be a wider problem across the country. In 1988-89, Michael Marmot came to India because he was co-author with McKeek in UK in the paper which showed that Indians had much higher rates of coronary heart disease, diabetes, pre-diabetes, and what's now called dyslipidemia and insulin resistance in comparison to both the Caucasians as well as the Afro-Caribbean population in the UK. So he came in and spoke to Dr. Paintal that time. He was the Director General of the Indian Council of Medical Research, and said, why can't we do a comparison between India and the UK? A study was proposed, but it somehow did not go through. But at that time, Dr. Usha Luthra was the Additional Director General in charge of non-communicable diseases, said, let's go through with an Indian study with two centers, Delhi and Vellore. I was to be the PI of the Indian study, and Dr. Krishnaswamy was the PI of the Vellore study. And therefore, the ICMR study of urban-rural comparison came in. We published some of our data in 1993 in the World Health Statistics Quarterly. In the same year, in the World Health Bulletin, there was a publication from Professor Gopinath and Chadda on their survey of coronary heart disease in urban Delhi. Both these publications showed not only that the prevalence of coronary heart disease was high, but our publications showed that there was a considerable gradient between urban and rural population, about a 2.5-fold difference between urban India and rural India in terms of coronary heart disease and in terms of hypertension, but a 3-fold difference in terms of diabetes. And now it was fairly clear that we were actually dealing with this problem, but there was an element of acculturation to urban environments, which was also influencing how this process was actually developing, and both in terms of manifest coronary heart disease as well as the risk factors. So the whole idea of Indians also within India being vulnerable to coronary heart disease became fairly apparent at that time. I must pay tribute to Dr. Gopinath at this point in time, because again, this is an opportunity for reflections. Here was the eminent cardiothoracic surgeon who built up the Department of Cardiac Surgery in All India Institute of Medical Sciences. Close to his retirement, he's lost or he had substantial impairment of his vision. And on retirement, without any formal training, he reinvented himself as a cardiovascular epidemiologist and went ahead and conducted a major study. And very importantly, and very few people have recognized and recorded this, he was one of the first to speculate, at that time it was speculated, to speculate that some of the urban-rural differences that are becoming manifest, including in our own study, could have been attributed to air pollution. He attributed it to heavy metals in the air pollution. Till that time, the world literature was pretty silent on the relationship between air pollution and cardiovascular disease. But that also shows the intellectual depth of the man, that he could actually now start thinking of all of those putative associations. But then anyway, this continued. But around that time, I invited David Barker also to come to India to participate in an international symposium on cardiovascular epidemiology and prevention in 1981. And David Barker, who was just at that time gaining a fair amount of prominence for his Barker hypothesis, linking intrauterine malnutrition and early childhood malnutrition to adult cardiovascular disease, then came in and we connected him to Dr. Santosh Bhargav in Safdarjung, who had been associated with a childhood cohort which had been assembled in the early 60s and which had then grown up and was now available as an adult follow-up, where not only maternal pregnancy weights were recorded, the child birth weights were available, and the growth up to 14 years was documented. And now we had a tremendous opportunity to look at their cardiovascular risk profiles and correlate it with the birth indicators. And thus was born the New Delhi birth cohort study, which is still going, possibly the third or fourth generation, and yielding very rich data indeed. But one of the seminal findings of that was the children who were born small in size and low in birth weight in particular, if they gained weight again between the age of 2 and 12, and by that time they actually migrated to the upper end of the body mass index distribution, they were at a much higher risk of developing adult diabetes and hypertension than people who probably had a higher birth weight to begin with. And the rebound adiposity concept of this kind of intrauterine and childhood malnutrition, the early life influences, also became fairly prominent in the Indian context. So we started looking at diabetes at this point in time, and again, the severe surge in diabetes in India has been phenomenal, but been very well documented, in some cases better than even documentation of cardiovascular disease. From about 2.3% prevalence of adult diabetes in the 70s, which Dr. Ahuja and others recorded. Now in Delhi, we were seeing 12 to 14% incidence of adult diabetes, and in Chennai, it had gone up to 18% and 20%, and now we're seeing much more. And in terms of combining diabetes and diabetes, recent data from Nikhil Tandon and others suggest that it's upwards of 70% prevalence of dysglycemia, as it is called, in Delhi. So the South Asian sweetheart syndrome, as we might call it, of diabetes, pre-diabetes and cardiovascular disease seemed firmly set. But was it all genetics? Because that is the simplest recourse to take. Blame it all on genetics and say that there's nothing much we can do about it. And then we looked at various aspects of it. Of course, there were international studies like the Interheart and others also, which looked at genetics, and number of studies in diabetes, international as well as Indian studies, which showed that the actual attribution to genetic variability was very minimal, and even the best of them predicted very little. But much more importantly, lifestyle changes or environmental changes like diet and physical activity trumped the effect of any gene, and you could actually overcome that. That was shown in the diabetes prevention trial, that was shown also in a number of other studies, that more than genes, it was the way actually we lived our lives that mattered much more in the expression of any susceptibility that existed. Therefore, we now come to a fair amount of realization that we need to influence whatever susceptibility exists, whether it's the epigenetically modified susceptibility of intrauterine malnutrition or epigenetically modified susceptibility because of various pollutants or dietary factors which increase the body adiposity and visceral adiposity and leave us with a reduced lean muscle mass and with insulin resistance both in the muscles as well as in other vital organs. So these are questions that do come up. But whatever be the nature and the determinants of that susceptibility, we do need to understand and alter that. But at the same time, we need to ensure that the conventional risk factors, which are so clearly demonstrated to be valid globally and very relevant in the Indian context, like tobacco use, smoking in particular, like hypertension, like diabetes, and like even obesity and unhealthy dietary habits, which lead to both high blood pressure, dysglycemia, as well as dyslipidemia. All of these are essentially things that we need to address and address through multisectoral and health system interventions. So this realization now is very clear. In 2016, when we have the global burden of disease data analyzed, and we have recognition that 62% of our disease mortality is due to chronic diseases, 55% of our disability-adjusted life year losses because of chronic diseases, and cardiovascular diseases top the list with 27% mortality, that between 1990 and 2016, ischemic heart disease in the males had jumped from the 5th position to the topmost position in terms of daily loss. In women, too, it has jumped from the 7th position to the topmost position now. And therefore, we are witnessing a tremendous transition in this country, and we can no longer afford to ignore ischemic heart disease as a problem of the West, or dismiss it as a matter of genetic susceptibility and turn our eyes away from what we need to do in terms of altering the social, environmental, and personal determinants of health. So we are now, in fact, even now, there are so many people who sort of react and say, it's all in the genes. I tell them, rather than blaming the genes we share, we should look at the genes we wear, whether we are still fitting into last year's jeans or not. So, therefore, we ought to be really looking at some of the issues related to the etiology. Still, we need a lot more research. What is it that we can do in terms of diet and physical activity that can alter some of the susceptibility that early childhood disadvantage and malnutrition confers? What kind of diet and physical activity patterns we need to ensure that our children have so that they grow more muscle and have less adiposity? All of these are important issues. But we do know enough to provide an active response, both policy-wise and program-wise, and that is where we have been falling behind indeed. And that's where I believe there's a lot more work that needs to be done. Indeed, if we look at again, talking about acculturation, let me give you an example of one more study. We had actually started studies in the factory populations, and firstly we did in Bharat Electronics Limited in Ghaziabad. Then we did it with 10 industries across the country, something that Professor Prabhakaran continued after we set up the surveillance systems there. And we have found very clearly that through Shah Ibrahim's study in 3 of these locations, where people who are living in rural areas and migrated to urban areas, within 5 years, their risk factor profiles were far more like the urban residents of a long time and far less like their own siblings who had stayed back in the rural areas. So through the sibling comparison studies, it was clearly demonstrated that it was the urban acculturation that was really transformative in terms of the risk factor profiles. So repeatedly we have shown that this kind of acculturation is taking place in urbanization, but in rural areas too we are seeing those changes. And unfortunately in the rural areas one other problem comes in. We still see a fair amount of hemorrhagic stroke where hypertension has not been detected, and therefore poorly controlled hypertension can result in stroke as the very first manifestation. In fact, even in urban Delhi, when we did qualitative research studies in the early part of this century and looked at the perceptions of people about cardiovascular disease in the middle-income, high-income groups versus the urban slums, the middle-income, high-income groups perceive cardiovascular disease as a chronic disease. But those in the slums perceived it as an acute problem, because for them the first manifestation was a stroke, often. Undetected hypertension. Therefore, we have a long way to go in terms of actually providing adequate capacity within our health system for early detection and management, good surveillance systems, good risk factor recognition, and effective interventions. And all of this brings us to the nature of response that we need to provide today. Why did I bring in Steve McMahon into the picture when Bairaji Foundation wanted it? Not because of the glamour that a very handsome young Australian brought in, and not only because we had affinity towards cricket. I should have started by congratulating Australians on their current victories, Esprit and Ashes. Once I would have done that at the beginning, you wouldn't have bothered about the rest of the oration anyway. I would have already got my brownie points. But certainly, I think the reason is that there is a lot of global knowledge we can share and benefit from. The Portuguese writer Miguel Targo said, "Universal is local without walls." Much of the knowledge and its application will have to be generated locally, but without walls. We have to be open to sharing that knowledge and collaborating. And that is where actually the universality of science and the universality of global health becomes particularly manifest. And therefore bringing in Steve McMahon, at that time the George Institute was not yet born in India, but bringing him in and bringing his colleagues in was an important venture, because there was another thing which was very attractive about Australia. Not many people in India know, not many people in the Indian media know, that among the sharpest declines in cardiovascular disease, in smoking rates, all of that has been in Australia and New Zealand. One of the most impressive public health victories against chronic disease, particularly cardiovascular disease and tobacco, has been in Australia. And there is no reason why we cannot benefit from that knowledge, and that's why I had requested George to come in, and Steve to come in, and George was born subsequently as a result of that. Therefore, while we are building up our own health systems and trying to bring in the influence of our thinking onto other sectoral responses, because we have to deal with air pollution, we have to deal with agriculture and food systems, we have to deal with urban design and transport, we have to deal with the education system. All of those are important when we're dealing with chronic diseases, whether it's diabetes or whether it is cardiovascular disease or even chronic renal disease. Now, we therefore are now trying to really look at how best we can actually utilize existing knowledge even as we are generating knowledge on health systems. Unfortunately, the policy response has been towards firstly ignoring the problem, saying that A, Indians do not have much of a problem, B, saying that it's only rich Indians who get it, C, saying that even if it's a problem, there's not much we can do about it. It's all a matter of personal choice, personal habits, and therefore trying to turn away from the problem. And part of this thinking has been conditioned by the fact that people in policy do not have the inclination to recognize it as a mass epidemic where they will have to invest a fair amount of resources. Because the moment you recognize hypertension and diabetes are major problems, you'll have to start thinking in terms of diagnostics, drugs and management, and chronic care, and reconfiguring health systems for chronic care from acute episodic care. And therefore, the reluctance in a health system which has been grossly under-resourced in terms of allocation to health is naturally not only to prioritize the problems of maternal health, child health and infectious diseases, which do continue to be priorities, but also to turn a blind eye towards the problem of chronic diseases. But finally, when the weight of evidence is borne upon them, and when they could no longer turn their Nelson's eye towards this, the response has been to look at putting money into tertiary care, putting money into health insurance programs, which will put in more stents, provide some support to dialysis programs or bypass surgeries for others. While care at the tertiary care level is certainly required for people with severe health problems, the insurance programs have not been very successful in reducing the financial burden, certainly not improved access universally, but most importantly, they'll continue to drain more money if you do not attend to early prevention and early detection and treatment of risk factors, and therefore neglect of primary health care is going to cost us heavily. And that is the lesson that needs to be brought in, but unfortunately policy does not pay much of an attention to primary care because that is, within quotes, not very sexy. On the other hand, setting up fairly large institutes which have public visibility is always going to be a matter of populist appeal. But we have to demonstrate, therefore, as a community committed to public health, that primary care is effective, is cost effective, can achieve results in a fairly short time frame so that even politicians can claim success. And therefore, we ought to be able to demonstrate how, even in a setting where health workforce is relatively depleted, that technology-enabled frontline health workers can actually work dramatic changes in detection and management of high blood pressure and diabetes. Again, Professor Prabhakaran is leading a number of studies in different parts of India showing how technology-enabled frontline health workers are remarkably competent and effective in detecting and managing high blood pressure and diabetes in different states, whether it's Himachal Pradesh or in Haryana or in Visakhapatnam or now in Tripura. We ought to be able to train primary care physicians in better detecting and managing risk factors and disease and not allowing it to develop into serious complications at a much later date, which is going to be tertiary care intensive. So we ought to be able to build in a fair amount of health system changes anyway, and we ought to strengthen our district hospitals in a meaningful way, particularly with public sector strengthening, in order to handle some of the more advanced forms of the disease without necessarily having to have people plug the corporate hospitals and the large medical college hospitals. So building up robustness in our health system in terms of chronic care, particularly in terms of early detection and management, is important. But if one lesson we have learned, whether it is in terms of the Barker hypothesis being proved relevant in the Indian context of early childhood influences, or in terms of the so-called epigenetic modification, or the exposure to air pollution being toxic to the vasculature, it is that we cannot deal with this segmentally. We cannot fragment the health system, we cannot segment the age groups. We have to take a life course approach. And therefore our intervention does start with maternal health and maternal nutrition, which actually influences the nutrition of the newborn. Ensure that early childhood nutrition is also adequate. Also, the growing child gets not only adequate nutrition, but appropriate nutrition, bringing physical activity back into our schools and into our lives, and ensure that urban environment is much more conducive to active and pleasurable living, safe and pleasurable physical activity, and promotes health, active living. And we ought to be able to tackle some of the issues like unhealthy foods by ensuring that their prices are increased through taxation, that healthier foods like fruit and vegetables are subsidized and produced in greater quantity, and also the post-harvest losses are reduced. I mean, all of these are important multi-sectoral initiatives we ought to be talking about. The banning of advertising of tobacco, increasing taxes on tobacco, banning of smoking in public places, all these are going to be important measures. So using fiscal measures, other policy instruments to reshape the social and environmental determinants of health is also going to be very critical. And that is something we need to do, and again, where we can learn a lot from Australia. We have collaborated with Australia in developing a case for plain packaging in India. And we know that Australia has been the leader in this field and has inspired many other countries now to follow suit. So there are many areas in which we can collaborate and learn from each other. And I believe that in terms of even looking at health beyond healthcare, in terms of policies and programs in other sectors, the broader concept of public health is something that we can learn from the Australian experience. So we therefore now need to ensure that we also provide institutional capacity for transdisciplinary research. We are fairly critical of policy, and sometimes quite rightly so, citing Bismarck's famous statement of the 19th century that there are two things that should not be watched while they're being made: sausages and public policy, unedifying spectacles. But nevertheless, enlightened policy can be made, but that demands not just scientific knowledge in terms of biomedical or epidemiological research. You do need scientific credibility, but you also require financial feasibility. You need operational steerability of the health system, and then you finally need political viability in terms of understanding what the opposition is and what the opportunities are. So we do need biomedical and epidemiological research, we need health economics research, we need health systems research, and we need social science research. Only when we can tie in these knowledge streams together will we have a recipe for the policymakers. Otherwise, if we only go with our own viewpoint, we are unlikely to make headway, because they have several other considerations to look at. And therefore, institutions such as the George and institutions such as my own, the Public Health Foundation of India, believe that our research has to be health system connected in the first place, but has to be truly transdisciplinary if it has to provide meaningful inputs into policy and programs. And that is where I believe we, as well as many other institutions who are represented here, should now work together as a team in order to provide that body of knowledge which can inform and influence policy. At the same time, we ought to be able to build in a very strong case for advocacy, implementation research, and then capacity building across multiple institutions and across multiple constituencies as well. I mean, whether it is the community health worker in the field, or the primary healthcare physician, or the media, who are actually going to be important allies in public education and also in challenging policy, we ought to be able to build a fair amount of capacity through our collaborative efforts. Therefore, there is a fairly large agenda for us to address, and I'm sure we'll do it well as George proceeds into its second decade. And we ourselves in the Public Health Foundation of India last year completed our first decade. And I'm sure as we all enter our teens, we will have some tantrums, we'll have some challenges, but nevertheless we will be active, energetic adolescents getting up for change and willing to provide along with them the leadership for the future in our own chosen sphere. I believe the role of a health professional, I've been frequently challenged what is the role of a health professional. I believe it is to elucidate as a researcher, to educate as a teacher, to alleviate as a clinician, to advocate as an activist, and if necessary, to agitate as a concerned citizen. So I believe all of us, in one way or the other, are performing these functions. And if we collectively can discharge all of these functions, we probably will see cardiovascular disease and chronic disease adequately responded to. People ask me, do you expect them to disappear? No. But it's a crime if a person dies of preventable cardiovascular disease before the age of 80. So it's the question of definitely at least postponing death and disability and greatly minimizing it that matters. So I think that is where we must face up to our challenge. And as St. George slew the dragon, may the George Institute also achieve its success in this area. Thank you. Finally, I'm sorry that my mother gave me a small jewel box. She had no idea you're going to be collecting so many jewels all over the world.
Thank you, Dr. Reddy, for that non-pulverized